Good evening. We meet again, and this week's unit is around the respiratory system. We're going to start with the structure and function of the respiratory system. We're not going to be dwelling on this too much because this is a pathophysiology class. It's not an anatomy physiology. Some of your assignments were geared towards you refreshing around those, mainly the functions, the physiologic functions of the respiratory system. So they will blend well with what we want to achieve in this week. So in this part of the lecture, we want to be able to differentiate, for example, between the conducting and respiratory airways and how the bronchioles um, up to and down to the bronchioles, that we don't have physiological events happening, rather we just have the conduction of the air. So they're kind of like the exchange point. We then we want to be able to trace the movement of air through the airways, beginning in the nose and oropharynx and moving into the respiratory tissues of the lung. That's why you were asked to do the diagram of the in your forum assignment. And then we are going to talk about how bronchial and pulmonary circulation differ, and then we'll talk about the basic properties of gas exchange in relation to the negative pressure and partial pressures and pressure within the thorax and pressure, atmospheric pressure. So we'll go through these as we move along. So first and foremost, we talk about the conducting airways. Those are the nasal passages, the mouth and pharynx, down to the larynx, down to trachea, bronchi, and bronchioles. This is in figure 29.1 in your book. So, like we said, other than functioning in to bring air in and out, they don't have a job in the perfusion. Oxygenation like end point at the alveolar level. They're made of cartilage, elastic, and collagen fibers. They also have smooth muscles that gives them that flexibility needed to maintain their function. And they're inside those conducting systems, you see those cilia that line them, and they have special hair-like projections. They also have serous glands that will secrete those fluid containing enzymes, anti-bacterial enzymes. So you can appreciate how the cilia and those glands with the secretions are play the first protective role of the lungs, and that cough is actually one of your mechanism in fighting allergens and infections. And really, if you want to talk about the respiratory system, you divide it into two parts: that conducting airways, and then you have the respiratory tissues of the lungs. Really, that is the those are involved in the primary function of the respiratory system, which is the gas exchange. So when oxygen comes from the air into those conducting airways, it ends up in those alveoli, and then you'll have that perfusion where and through the process of diffusion the CO2 and O2 get exchanged, and that's where you have the oxygenation happening. Um, in addition to the fact that the lungs play a role in gas exchange, they also have a role in the metabolic stability, because they really control acid-base balance as well. So what are some of the things I want to highlight in the structures of the airways? Of course, you need to always refer to your book and read your chapters. But when we talk about the nasal passages and their importance in the airway structure. The nose is the preferred air entry route because of the fact that it humidifies, warms, and filters the air. But if you have septal deviation or blockages, you see the person mouth breathes from the mouth. The pharynx, we are concerned because sometimes if the pharynx has any swelling due to injury, infection, it can literally cause airway obstruction. And remember, we have the ABCs of life: airway, breathing, circulation. So a simple pharyngitis can cause airway obstruction. Larynx is the next, and the larynx has two folds, two roles. One role is in the air passage, and the other role is the through the uh, speech. And because we have the vocal folds in the lower part of the larynx, that produces the vibrations, and then we have those vocal sounds. After the larynx is the trachea, and in the trachea, really trachea, bronchi, bronchioles form that tracheobronchial tree. If you look at the lungs anatomy, you see that the right main bronchus is more straighter than the left. So if somebody is gonna aspirate, chances are it's gonna go into right bronchus. Um, they will divide and get smaller and smaller until where you'll have those alveoli, which are not part of the conducting, they're part of the respiratory part of the respiratory system. But they form like a tree, and the alveoli, you can think of them as the sac or as the leaves of the on the tree. What do you need to know? That system, like we said, it's cartilaginous rings. That's mainly how it is made of. You also have the fact that be they can constrict. So these are some of the main things you're gonna remember. Bronchodilators work on that level. Um, the lungs, the right lung, remember it's a three lobes. The left lung is a two lobes. What else is there to remember from here is the as they branch out and reach to the terminal bronchioles, their structure really changes. So the cartilage part of the structure is less and less, and the smooth and elastic tissue increases in those terminal bronchioles. So in brief, the respiratory tissues, that's where gas exchange happens. They're not lined up with the cartilages part, rather they're more of a sponge-like tissue, and that's where the alveolar air sacs, again, they have also lymphatic structures surrounding them, and the real gas exchange happen at the alveoli level. What happens is these sacs of alveoli, they're surrounded by interstitial space, and then at the boundary between those alveolar sacs and the micro vessels, that's where when the diffusion happens, where oxygen carried by the hemoglobin comes into the um, it's by passive diffusion, because oxygen is going to be more concentrated in the alveoli and goes into the vessels, and CO2 is going to be more concentrated in the vessels. It goes into the lungs and they go back, and that's the fact of gas exchange. Um, we talked about this, so I'm just, you can read those in your chapter book. The lungs, they have the apex and the base, and when we talk about the apex and the base, it's different than the heart. The base, the apex of the heart is in the lower part, and so that's where you get the apical heart rate in that fifth intercostal space. The lungs, the apex is the upper part, right here near your clavicle. And so the base is the lower part of the lungs, and that's where you say, basilar or whatever, atelectasis, is that they're talking about the one down near the diaphragm. So when we talk about respiratory system, we talked already about diffusion. We talked about ventilation perfusion. You'll hear that term VQ mismatch, and Q represent the perfusion. Uh, what happens is you get the air from the atmosphere through the airway passages, and it gets to the alveoli, and then that what I told you, the blood is sitting right there at the alveolar sac. And so the exchange happens. Naturally, the exchange happens by diffusion, like I told you. And that's how oxygenation happens. These components will get the adequate oxygenation going. Um, this is what I want to talk about now. We will talk about the problems later on. So again, the act of inspiration and expiration is part of the ventilation movement. So air drawn into the lungs and the expansion of the chest cavity versus the expiration where the chest cavity goes smaller back again. These are the mechanics, of the pump, which is the lungs for the ventilation to happen. Again, you're dependent on that conducting airways for adequate ventilation. But again, other than these, you have the intercostal muscles that are part of the respiratory system function. So those are accessory muscles for breathing. You also have the diaphragm. The diaphragm is that dome-shaped muscular partition that separates the thorax from the abdomen. It has a major role in breathing. When it contracts, it increases the volume of the thorax, and so the lungs will inflate. And the diaphragm is innervated in the C2 to C5, C4 level, and that's where we saw in spinal cord injury people getting quadriplegic with injury at the higher C level. So remember we talked about alveoli as the terminal air spaces of the respiratory system where really gas exchange takes place. They're cup-shaped, thin-walled. They're separated by from each other by thin alveolar septa or like kind of interstitial space. Um, they are there are two types of cells, type 1 and type 2 alveolar cells, but they contain those brush cells, macrophages. We're going to talk about brush cells also again in the GI system, and these are act as receptors to monitor the quality. Mostly these cells, when they're there in any system, they're like protective. The macrophages here, they will function to remove any injurious material or offending material from the lung. So what do the type 1 alveolar cell do? They're squamous cells. They're also known as type 1 pneumocytes, and they're the most abundant cells in the alveoli. The type 2 alveolar cells are called type 2 pneumocytes. They're the cuboidal cells, These cells they are as numerous as type 1 cells, but they don't look like the same, and they cover only 5% of the surface. What is important with type 2 alveolar cell is that they're the ones that synthesize the pulmonary surfactant. That pulmonary surfactant is essential for life. What it does is it creates that tension in alveoli, allowing them to stay open. So if you think of alveoli like a balloon sac, the balloon, if you release the air from it, it's going to collapse. What the surfactant does to the alveoli is gives it that surface tension, and then they remain open because you cannot afford to have alveoli that are collapsed. So there is these two circulation that happen in the lungs. The bronchial circulation really distributes blood to the conducting airways and the supporting structures of the lungs. The pulmonary circulation arises from the pulmonary artery, provides for the gas exchange function of the lungs. So going back to some of the physics or chemistry or biology you took in high school, and remembering your anatomy physiology, you know that the basic gas in the air is a mixture of nitrogen and oxygen, and they combine those gases produce the atmospheric or barometric pressure. At the sea level, it's considered 1 atmosphere, which is 760 millimeter of mercury, and that's how they're measured. You remember those units, and you need to be able to incorporate them in your learning. So when they talk about respiratory pressure, they make it relative to the atmospheric pressure, where here the value is 0. So the respiratory pressure will be positive 15. It means that the pressure is 15 millimeter above atmospheric pressure. And when we talk about minus 15, we mean that it is less than 15 less than atmospheric pressure. Usually, instead of saying millimeter Hg, they talk about those pressure in centimeter water. And what they're talking about is the pressure exerted by a single gas in a mixture, and they call it partial pressure. So that they'll say partial pressure of oxygen, partial pressure of CO2, you know. The pressure exerted by a single gas in a mixture is called the uh, partial pressure. And for example, PO2 denotes the partial pressure of uh, O2. So to give you a clearer idea, if we take that the concentration of oxygen at 760 millimeter Hg, which is 1 atmospheric pressure, is 20%. What that means is that you multiply 760 times 0.20, and you end up with a partial pressure for oxygen of 152 millimeter Hg. It will make sense as we progress. The um, what you need to also know coming up is that your um, degree of how much the lungs inflate and deflate, in addition to depending on the diaphragm, on the respiratory pressure, you also are dependent on that compliance of the lungs having those adequate surfactant, and on the airway resistance. Are they the airway constricted or not? So there's so many factors that play into the effective ventilation. Question that comes to you: which of the following is directly responsible for gas exchange? And really, trach, bronchial circulation, bronchial pulmonary circulation are all not. So the respiratory membrane is the anatomical site of gas exchange in lungs. because it is that one thing where it lines up the alveoli where exchange happens. Okay, respiratory pressure. We hear the terminology intra pulmonary pressure or alveolar pressure. So what does that mean? Um, the intrapulmonary pressure or alveolar pressure is the pressure inside the airways and alveoli of the lung. The gases in this area of the lungs are in communication with the atmospheric pressure. When the glottis is open and air is not moving into and out of the lungs, such as in inspiration or expiration, the intrapulmonary pressure is zero, which is equal to the atmospheric pressure. The pressure in the pleural cavity is called intrapleural pressure. And the pressure when the lungs is normally inflated, it is always negative. So that's what you hear about negative pressure in the lungs. So when the intrapleural pressure of a normally inflated lung, what is the pressure? It is a negative in relation to alveolar pressure, and it's usually around -4. And it has a nice explanation for it in your book if you wanna learn more about it. We're last we have to talk about intrathoracic pressure, which is the pressure in the thoracic cavity. This is equal to the intrapleural pressure, and it is the pressure to which the lungs, the heart, and great vessels are exposed. So if we do forced expiration against the glottis that is closed, such as when we do defecation or Valsalva maneuver, we see an increase in intratracheal pressure and increase in intrathoracic pressure. And that increase in intrathoracic pressure, because it increases these organs, the lungs, heart, and great vessels, you'll see the venous return will be impeded to the right atrium. And I'm sure you still remember the information is fresh about the cardiovascular system in your mind. Um, some of those concepts that we have to talk about is lung compliance, and it is really change in volume, change in pressure. Just understand the concepts of those. Airway resistance, how much that movement of air is having to face. It's similar to the systemic vascular resistance with the blood pressure, how much it should, uh, um, how much the heart has to pump against the systemic blood pressure. And here's the same. Um, and it is related to those pressures that we've been talking about a minute ago. Tidal volume is one number or unit that you're going to hear a ton about, because it is the amount of air that moves into and out of the lungs during each breath. Reminds you of something in the cardiac? Yes, stroke volume. So versus when we talk about inspiratory reserve volume, and that's the maximum amount of air that can be inspired in excess of the normal tidal volume. So if I do, that's my tidal volume, but if I do all the way, that is the maximum air. So we usually just do the tidal volume, and it's usually in subconscious, natural, spontaneous breathing. We don't make an effort in it. And then you have the expiratory reserve volume, the residual volume. You're asked to find definitions for those, so I look forward to reading your forums. Lung capacity is something that they use to measure the lung function, and also all these numbers you're introduced to because they are used into exploring how effectively the lungs is working. Or if you want to measure the vice versa, if the patient has asthma and you want to say Is it affecting the functional ability, the functional reserve in the lung, the vital capacity, inspiratory capacity? This is how they where they use them mostly. And here is the same, these term terminologies. They're not the same test. Each one is testing something, but these are all used in that respect. Pulmonary function studies are also used to gauge, for example, how bad is the asthma, the COPD, and they are measures, same like how blood pressure measures if you have hypertension, and how temperature measures if you have fever. They do help in the measurement of. Again, here what we're trying to see is what's the maximum amount that can be breathed in, what is the maximum amount of air that can be expired, and then with that, what we're trying to do is really uh, define and see the person's breathing, and they can help diagnose how the problem is affecting functionality. Because at the end of the day, you care for how functional your patient is. This is still in the same realm as the others. Okay, and here this question is asking you which of the following is the vital capacity. And the answer is, if you look at the figure 2917, you see that vital capacity is around 4,800. It includes the expiratory reserve volume, which is around 1,200, the tidal volume, which is around 500, and the inspiratory reserve volume, which is around 3,100. So that's the average in there. And we talked about these as part of the pulmonary gas exchange. We talked about them and how the ventilation perfusion happens. This is where we review and reiterate the fact that it's a quotient, it's a ratio. Ventilation happens adequately, it's kind of like 100%, and then perfusion is happening adequately, so 100 to 100. But actually, there is some discrepancy. If you, the amount of oxygen when I'm inhaling up in my nose and in those conducting airways, it's going to be high. The pressure of oxygen, the presentation of oxygen, it's higher than CO2, for example, whereas at the bottom level, it's more of a CO2, less of O2. So you see the number goes down. The average is 100%. If you look in the upper apex level to the base level, you're going to see 100%. So the VQ is always kind of like a one-on-one average. Where would you see mismatch is in conditions, and I will teach you about those. There's few terms that we have to introduce still. Um, we talked about the diffusion before. The bulk really it represents the air domination in the upper airways, versus when you talk about diffusion is more of the part of the gas exchange. So dead space, what does dead space mean? When we talk about dead space, we're talking about space that must be um, when you're with each breath, what is something that is not participating in gas exchange? So the air really moves through so many dead spaces that are not part of that gas exchange. And there's two. You have the anatomic and the alveolar dead space, the physiologic dead space. So the anatomic dead space is what's that in the conducting airways. The alveolar dead space is that in the respiratory portions of the lung. When they talk about them, they're almost like 150 to 200 mLs of dead space, depending on the size. And that's the air that is in the nose, in the pharynx, in the trachea, in the bronchial tree, and that is just being there. It's not participating in the air exchange. But we know we can't have those areas without air. It's just a fact that they're being there. They're part of the physiologic dead space that happening, and that uh, is is uh, is and okay. So the anatomic dead space and physiologic dead space in normal people, they're the same. We'll talk about when they become different when conditions differ. So, but remember the concept of that space. Shunts also, we talk about shunting. So when we saw the diffusion, the blood goes from the air goes into the sacs. They find a good place because the alveolar sacs are empty, waiting for the air, and then diffusion happen and gas exchange happen. But when we talk shunting, it means it came tangential and it did not happen. That could be from multiple reasons, and we'll discuss them in. I'm gonna bring a visual so you can see that. So as you can see in this um, image, they're talking about the structure. So we have this. Um, in the center, we're seeing a normal matching of ventilation perfusion. So you have ventilation happening nicely here, and the perfusion is good. In the first one to the right, you have um, um, a perfusion but without ventilation because the ventilation is stopped. Here you have ventilation but without perfusion. So this is kind of what they when talking about shunt, like the things supposed to happen but they're shunted. Matching ventilation and perfusion, really there should be the dead space should be negligible, so the anatomical dead space should be equal to physiological dead space, and there should be no shunt, and there should be the physiological exchange and uh, resulting in adequate oxygenation. What could affect the oxygenation between the alveoli and the capillary? The surface area available for that diffusion to happen. If there is pulmonary edema, you see more water, it's going to be very hard to have that diffusion. How is the alveolar capillary membrane, how thick they are, so that physiologically, the partial pressure of the air and gases and the solubility of those gases and how they can diffuse. When we talk about oxygen carbon dioxide transport, really there are some elements that contribute to that, and typically they have a normal value. PO2 is 80 to 100, really above 80 because it could be 120. It's not harmful. But one thing that is mentioned and is of importance is that relation between the oxygen carried in combination with hemoglobin and the partial pressure of oxygen of the blood. And that's called the oxygen hemoglobin dissociation curve. And that you see in this figure, and it is in your book. You have beautiful boxes, tables, and figures that depicts the ideas in a more user-friendly. So here you're seeing the partial pressure of the oxygen in the lungs, and they're represented. When you look at the B, it represents for you that there's going to be a shift to the left and shift to the right. So more left boxed area represents the um, in the effect of the body temperature, for example, and arterial PCO2 and pH on hemoglobin affinity is represented by that left side change or right side change. So a shift of the curve to the right, it happens because an increase in temperature of PCO2, and decreased pH favors release of oxygen to the tissue. So you see a decrease in temperature or PCO2, increase in pH shifts the curve to the left and has the opposite effect. Um, Oxygen and carbon dioxide transport, again, the PCO2 also has a normal level. Here, it's not like you can't have a higher than or not. 35 to 45, it's a legit number. If it's less than 35, it's low CO2. If it's hypocapnia. If it's more than 45, it's hypercapnia. And again, it presents in couple of form. The carbon dioxide is one. So it's carried also on the hemoglobin. The oxygen has more affinity to hemoglobin. The next that's more stronger to cling to oxygen is your uh, carbonic acid, and that's more dangerous. But the acid-base balance here, the formula is based on how much bicarb level is in the blood. Uh, Again, we see nervous system affecting all the movement of the lungs. Definitely, we spoke about the pharynx nerve pacemaker and where it is situated up into the spinal cord injury. But let's go back to the real control of the lungs. Unlike the heart, where you have that autorhythmicity, all those things you saw that the heart can do on their own, the muscles that control respiration require continuous input from that nervous system, and it doesn't do anything on its own. So the movement of the diaphragm, the intercostal muscles, the sternocleidomastoid, and the other accessory muscles, they control the ventilation is in the pons and medulla neurons. So in the brainstem, and really that's the respiratory center. And so the respiratory center is based on those group of neurons, and they control the spinal motor neurons of the intercostal and abdominal muscles, and as well the other neurons control the activity of the phrenic nerve, which is the nerve that innervates the diaphragm. And interestingly, the tracks that control expiration and inspiration are spatially separated in the cord. Um, so does the coughing, hiccuping, and voluntary control of ventilation. Um, when we talk about other regulation of breathing, we have automatic and voluntary components. So the automatic regulation is the input from two types of sensors, the chemoreceptors and the lung receptors. Chemoreceptors monitor blood levels of oxygen, carbon dioxide, the pH, and then they control the breathing, the ventilation to meet those metabolic needs. The lung receptors, they monitor the breathing pattern and the lung function. Um, The voluntary regulation of ventilation integrates breathing with voluntary acts such as speaking, blowing, and singing. These acts, which are initiated by the motor cortex, cause a temporary suspension of automatic breathing. So the automatic and voluntary components of respirations are regulated by afferent impulses transmitted to the respiratory center from different places, and you saw those different places where they are. A cough reflex, we need to really understand the cough reflex because coughing is a protection for the lungs. It's a neurally mediated reflex. When we have accumulation of secretions, we cough, and when something irritating, destructive comes, we cough. So it's one of the primary defense mechanisms of the respiratory tract, and it's initiated by receptors located in tracheobronchial wall, and these are extremely sensitive to any irritant, and also when there is excess secretions. The cough requires a rapid inspiration of a large volume of air, followed by rapid closure of the glottis and forceful contraction of the abdominal and expiratory muscles. As they contract, intrathoracic pressures is elevated, and then there's a rapid opening of the glottis, and at that moment you see the explosive expulsion of air. What does kinase talks mean when we talk about the breathing? We'll talk about a couple of abnormal. Kinase talks is when the person is breathing, but there is dysregulation in how fast they breathe, and because it's affecting um, the center for breathing. So you'll have those difference between a patient going from a state of hyperapnea to a state of apnea. Usually it is in response to a change in acid-base balance. So you see this so much in diabetes ketoacidosis, but you can also see it with brain injury. What is dyspnea? It is a subjective sensation. It is a symptom, not a sign, of a person's perception of their difficulty of breathing. So it includes, how do they feel that their breathing is labored to the reaction to that. So dyspnea, breathlessness, shortness of breath, they may be used interchangeably. We see that in primary lung diseases such as pneumonia. We see it in heart diseases such where we have pulmonary congestion, and we see it also with neuromuscular disorders, where in conditions, for example, where we have myasthenia gravis. Um, uh, Although dyspnea is a respiratory, problem, also can happen when we're exercising, and we can call that exercise-induced reactive airway disorder. Uh, So when the lung receptors are stimulated by the contraction of the bronchial smooth muscle, the stretch in the wall and the pulmonary congestion, what happens is there will be information transmitted to the cortex saying that there's this discrepancy between increased effort of breathing and inadequate, respiratory contraction. And so what happens at the end is that once all those discrepancies are felt by our brain, then receptors transmit signals that bring about the awareness that we are having breathing difficulty. We come to the conclusion of this chapter along with you doing the forum and doing the pre-reading. For this, you should be well equipped for us to start alterations in the conditions. This final question, just to tease your knowledge, which of the following accurately describes your breathing pattern after running to class? And if you say dyspnea, it would be correct because we spoke about, that feeling that we have that, um, what did we say, difficulty to breathe. It can also happen with a person after running for a few hours. So that is because we're aware of the breathing discrepancy. It doesn't always have to be a bad thing that is causing it. With that, I will conclude.